Hi, everybody. Welcome to the final Insight Night of the 2025 cycle, which is being brought to you by the Global Health Programs in partnership with the Pandemic Emergency Readiness Lab. I'm really excited to be here with you tonight. If you want to turn your cameras on to engage with the speakers, that would be great, but no pressure. My name is Maria. I'm one of the student researchers of the 2025 Global Health Scholars cohort. As part of my project, I had the great privilege of traveling to Elgeyo Marakwet County in Kenya, where I used participatory research methods to investigate adolescent beliefs and practices regarding nutrition and sexual reproductive health. Before we get started, we want to acknowledge that, first of all, the field of global health has roots in colonialism and the exploitation, marginalization, and violation of Indigenous and racialized communities across the globe. Thankfully, there are significant efforts across the world being made to deconstruct and rebuild global health as a field that stands for inclusivity, diversity, equity, and justice. But as such, as part of this process, it's important that we continue to do line acknowledgements to recognize the ongoing difficulties and challenges and violations that colonialism presents to racialized and Indigenous communities specifically. So this is a small step towards truth and reconciliation. I hope you will follow along with me. So we wanted to say that McGill University is located in Jojage, which is the traditional territory of the Kanien'kehá:ka, the keepers of the eastern door of the Haudenosaunee Confederacy. Jojage is a part of Turtle Island, also known as North America, a region that has been and continues to be deeply affected by colonialism. The land we stand on today and the resources we benefit from are unceded. As such, I invite all settlers present, whether Canadian citizens or, like me, foreigners to this land, to recognize the impact of our presence in this territory, as well as any other land that was stolen from Indigenous communities that we may benefit from. Particularly in the context of public, global, and planetary health, which is what brings us together tonight, I invite you to reflect on the ways in which the institutions in which we rely on, benefit from, and uphold at times perpetuate colonialism and cause direct or indirect harms to the Kanien'kehá:ka and other Indigenous communities across the globe. As we continue to work, research, and study health, I urge you to be mindful of the systemic barriers and violences that Indigenous communities undergo as a weapon or as a byproduct of colonialism. We could spend the whole night remembering the many victims of anti-Indigenous racism in healthcare, but I've decided to bring to you, to your attention, two cases which feel very personal to me. So as such, I ask you to remember them as well as the other victims of racism and colonialism in healthcare. So first, I ask you to remember Joyce Echaquan, whose death inside a Quebec hospital was a direct result of racism and colonialism. And I also ask you to remember Jordan River Anderson, the little boy who passed away in a Manitoba hospital instead of in the comfort of home because the provincial and federal governments could not agree on funding jurisdiction for the home care he deserved, all because he was a First Nations child. If you do not know these stories, I sincerely urge you to look into them and take the time to learn because they speak a lot about the ongoing consequences of colonialism in Canada and can be extrapolated to other regions of the world as well. So thank you so much. I'm going to pass it over to Mr. Kevin O'Neill, who is the program manager of the McGill Global Health Programs. Thank you.
Great. Thank you, Maria, for that thoughtful land acknowledgement. We really appreciate it. And welcome, everyone, and thank you for joining us online on this on the eve of this extraordinary weather event here in Montreal that has forced some of us to stay home and revert back to a format that we became so familiar with only a couple of years ago. As Maria mentioned, I'm Kevin from the McGill Global Health Programs Office. We're thrilled to be teamed up with the Pandemic and Emergency Readiness Lab tonight to bring you this session with our special guest, Jason Gale. And I just wanted to send a quick shout out to our McGill Global Health scholars who are joining us online tonight. This evening marks the final gathering for this year's cohort of scholars. And I'm sorry we couldn't meet up in person tonight, but I wanted to thank you all for your engagement over the last year. You've been a really amazing group. So thanks so much. And on a very quick housekeeping note for Global Health scholars, I'll be sending out the final survey for the Scholars Program just in the next few days. So if you could just keep an eye out for that, that would be great. And now I'd like to pass the mic on to your hosts for the evening. So Dr. Duane Liu is the director of Pearl, and a professor in the Department of Global and Public Health here at McGill, and the former international president of Médecins Sans Frontières. And Prativa Baral is the deputy director of Pearl and an assistant professor in the Department of Global and Public Health as well, with a background as an infectious disease epidemiologist. So over to you, Joanne and Prativa.
Thank you very much, Maria and Kevin, and welcome everybody to this event. And then we have the immense pleasure tonight to welcome Jason Gale. Jason Gale is a journalist who's been basically writing on global health issue for a few decades already. And I had the immense pleasure to meet him online, like tonight, through at the beginning of the COVID-19 pandemic. He he started to report in 2005 on H5N1, and then since then has been like a bit like a hunting reporter on the epidemic across the world. And so he has won many awards, for his contribution. And then his more recent big, I would say, endeavor has been this book called After COVID. And then we're going to talk about this book tonight. So welcome, Jason, who has flew all the way from Melbourne to join us today. He's in Montreal, so he's very close to us, but in a close distance way through the virtual. Welcome, Jason.
Merci, bonsoir. Merci beaucoup pour l'invitation. Now
Thank you.
switch to English.
So I told Jason that he has a very good French accent, and then we are very very pleased about his language skills. So um So I think that we have a young crowd here, and then people are very very interested in people's trajectory. And I was wondering if you could talk to us about how did you get from being a journalist to this global health journalist writing a book on COVID, and then you have done as well some specific training on the health, global health security. So walk us through this for a few minutes.
Yeah, so I've been at Bloomberg for 26 years. Bloomberg, as you probably are aware, is mostly a financial, economic government news service run out of New York, owned by the former mayor of New York, Michael Bloomberg. I joined to be a commodities reporter to report on beef and wool and wheat and cotton and sugar and all of those sorts of things because I had experience growing up on a farm. I was reporting on those things for a while and relocated to Singapore. And around the same time, avian influenza started spreading around Southeast Asia. And Bloomberg decided that since I was reporting on commodities and poultry were commodities, that I should be the bird flu reporter. And I knew nothing about viruses. My wife at the time is a medical doctor, and she thought it was inappropriate for lay people like me to be dabbling in her domain. And I took that as a challenge. So I decided to read her textbooks, and it was actually thanks to experts like yourselves who sat me down and gave me so much of their time and educated me that I learned about avian influenza initially, and then Bloomberg decided to create a healthcare team in Asia and put me in charge. So I had to learn about diabetes and cancer and all kinds of different diseases. And so that's kind of where I was for a while. And then I was working out of Sydney and decided to do a master's degree in health security. I did a thesis on the use of bacteriophage to mitigate the threat of antimicrobial resistance. A little odd. But I took a epidemiology subject, and that was hugely helpful. So I guess throughout this journey of just acquiring knowledge that I've been able to fortunately use and apply in my reporting. Maria was asking a question before we began about the coursework that she's doing and where that may lead. And I think in journalism, I think the main point is to be curious. And I think probably many people here are curious, and you can use that curiosity in different ways. I've used it to write about global health and medical science. Yeah, I think it's good to think laterally about how you can use your qualifications and where it may lead. But do consider journalism. We definitely need good science communicators in the field.
Thanks. I think that's really great to see your journey and how it has come about. Um, and how did you get the fantastic idea to write a book and document about the COVID-19? Because I went through the experience of writing a book. I think it's your first book, and I always call it a FBI, une fausse bonne idée, because it takes so much of your time, and you end up being, it becomes your like hobby for like 2 or 3 years in your life. So I was wondering, how did this germ in your head, and how did you went through the process?
Yeah, I think as I was reporting on COVID, from the beginning, and learning that it didn't, we were very fixated in the beginning on hospital beds and deaths and that sort of acute situation. But I began realizing that there was so much more, there's so much more morbidity and mortality beyond that acute phase. People dying 90 days after being out of being hospitalized, the risks of significant illness and mortality still being there, and even today still being there. So that was something that was overlooked, and I felt as though I had in interviewing literally hundreds of people, a lot of information that wasn't perhaps well recognized, and I thought there would be value in documenting initially how the pandemic unraveled, but then looking at the broad health effects beyond just the mortality and case numbers that we were all sort of immediately fixated on.
Right, because it's written after COVID. A lot of people will just say, and I see some of my friends and acquaintances will say, it's not yet after COVID. So, but you talk about the scars of COVID, and I was wondering, while you were writing this, is there things that really surprise you, that you learn and just say, oh my God, I didn't realize the impact of this or that. So yeah.
Ah, actually, one more recent story, it only came out a week or so ago. It was a story looking at the neurocognitive effects of COVID-19. I interviewed the clinical director of the US National Institute of Neurological Disorders and Stroke, Avindra Nath, and early in the pandemic, when people were dying in large numbers, often, this is in New York City, in large numbers, often at home and were dying surprisingly, like they were kind of relatively healthy and suddenly they were dead. And often, many of the times they were tested negative for COVID, so it wasn't immediately known to be a COVID death. And the medical examiners weren't able to figure out the cause of death. So these patients, the deceased, were their remains were sent interstate for autopsies, and a number of them ended up at the Walter Reed Military Hospital in Bethesda, Maryland. And this neurologist Avindra Nath was working across the road, and he was getting brains actually from these patients who had died mysteriously, and he had done some detailed analysis, imaging and microscopy, and discovered that many of them had neuronal loss in a part of the brainstem known as the pre-Botzinger complex. It functions as the body's breathing metronome, and they had lost these neurons and they weren't getting the signals to breathe. And so they essentially asphyxiated. And then after that, Dr. Nath was getting patients coming to see him describing these symptoms, which are known colloquially as Ondine's curse. And so I wrote about this a week or two ago, and it was a story that talked more about the neurological complications of COVID-19. But after writing that, I was getting a lot of emails from people saying that they also had experienced this being unable to breathe. They wouldn't sleep for days. It was really scary just not having the drive to breathe. And eventually they were able to get some relief. But that was really surprising. Now I've put them in contact with Dr. Nath, and he wants to do a case series on these patients. So that was a surprise.
Yeah, and you've just written a great piece on that.
Yeah.
Yeah.
Thank you. Yeah.
And then for people who I'm not a big Greek mythology person, before I pass over to Prativa, but the Ondine syndrome, that is something we study anyway in pediatric, is basically people who are affected by the fact that they lose their drive of breathing when they're sleeping. So and so it comes from Greek mythology. That was a curse that someone was given. So Ondine was given that curse. So yeah, that's more or less it. But over to you, Prativa.
Thanks, Joanne. Thanks, Jason, so much for being here. And I mean, just listening to you speak, I just feel like oftentimes when we think about the pandemic, we think about it from a very acute perspective, but we're still very much learning about all of the long-term intended, unintended consequences, not just with the virus, but also all of the mitigations that we had to put into place to deal with the collective trauma that we all went through. So I'd be curious to hear, you're a journalist, obviously, and so just getting your thoughts on the narratives that we've kind of created to rewrite history, and thank you for recording everything that has gone on and that is still continuing on. Your book very much argues that the pandemic isn't over just because we've moved on, and the anecdote that you just shared is very much an example of that. But why do we rush to forget collective trauma? And why do we keep doing that every time there's an emergency?
Yeah. Look, I think it's sort of human instinct. And I think that we have this idea that part of being resilient is to put bad things behind us and move forward. So I think we get some mixed signals around that. Because I think what we went through collectively was very traumatic on, for different reasons, for different people have different trauma from it. I know that I haven't experienced any personal loss of anyone close to me, but I wasn't able to see my father who was dying from cancer because of closed borders, and that's pretty minor in the scheme of things. But it was still for me traumatic. So I think when we consider the cumulative trauma that we as a species experienced, it's pretty bad. And we need to reconcile that and remember it, because I really think that what societies remember shapes what they're willing to pay for, and whether that's willingness to pay for long COVID clinics or preparedness or um, the labor force implications. Like there are a lot of reasons why we need to be taking full account of what just happened and trying to think of how we can do a better job next time. Because as Joanne and I were discussing, we know that there will be more outbreaks, sadly, like this.
Thanks, Jason. And I'm reflecting on this fact that a lot of the folks who are in the audience today are students. And so part of writing history or writing while these events are happening is also giving students the tools to be able to write about it. And so at the beginning of our chat today, you talked a lot about how we need science communicators to be, more present. So I wonder if you can speak a little bit about how we can better bridge the links between science and communications. And I think that's something that we all need to rethink, particularly in academic institutions. So any advice that you may have for students and academics who want to play a stronger role and be allies to cover some of these events to make sure we never forget the details of crises like COVID.
Yeah, actually, one of the things that came to mind as you were speaking was the fact that when we have a novel virus causing a new disease, there are no experts in this. We're all learning. Patients, doctors, researchers, journalists, we're all learning together. So I think there is space for everyone contributing to that learning process. And we saw remarkably the long COVID community educating us all on what that looks like, the symptoms, the broad array of symptoms, and there were so many things that patients themselves brought, and we owe them a great deal of gratitude. So, I think unfortunately, the nature of these events means that everyone can participate in the information gathering and sharing.
Absolutely. I'll just tag on to the long COVID component that you just talked about. I know this was a big part of the book. And I remember, to your point, I remember being on X, then Twitter at the very, very beginning when people didn't even realize what it was, what it meant. And it was a lot of patients that were advocating for themselves because they just were not receiving the care, because nobody knew what was going on, right? So, can you talk a little bit about some of the most underestimated long-term consequences of COVID with regards to long COVID and whether health systems today are prepared for this chronic aftermath, with regards to this emergency?
Yeah. So one of the things that sort of I think becoming increasingly um, concerning, it comes from the signals around the neurocognitive aspects of long COVID. We're seeing very good data showing this association with an acceleration in neurocognitive decline and impairment, which is likely to accelerate neurodegenerative diseases like Alzheimer's, dementias, and potentially Parkinson's disease. So I think that's an area where we need to be paying special attention because the burden of those diseases, for which there are no cures, they're very costly on societies and individuals. Families are heavily burdened by this. So we need to be paying attention because if this signal is in fact the start of a large wave of an increased incidence of neurodegenerative disease, then our health systems need to be adequately supported. There needs to be a lot of support built into systems to cater adequately for that.
Absolutely. And I also think, and for folks online who are also epidemiologists or scientists, it's really hard to measure something like long COVID, right? It covers a big umbrella and it includes so many things. And so just advancing research on something that we don't fully understand, whether it's long COVID, whether it's all of these other unintended impacts of the collective trauma that we went through is tricky. I wonder if we can try to find a little bit of positive in this conversation and see if you can suggest whether there are, based on all the reporting that you've done, whether there are any studies that suggest that vaccination, for example, significantly reduces the risk of long COVID. I know it's not zero, but mind elaborating on that?
Yeah, the studies around that have all shown that the vaccination does provide a degree of protection against long COVID. It's certainly by no means a perfect barrier. We know of many people who have developed long COVID and other complications from a SARS-CoV-2 infection after they have had all of their vaccinations and have been up to date. And so it's by no means a perfect barrier. And we know that it's important to look at the other measures to reduce the risk of infection. Face mask wearing in indoor crowded places where you're going to be sharing air with other people, and the use of air filters and ventilation and things like that we know are especially important. But I think that there have been other silver linings. The biggest, I think, is that throughout history, infection-associated illnesses, chronic conditions, post-acute syndromes, they've always been with us. If it's from polio or Ebola or influenza, these have existed, but the sufferers have often, suffered in silence and without any, proper recognition of these effects, and have been historically gaslit by the medical community. And I think now there's enough of this. Unfortunately, there's enough of this cohort that we can't ignore it. We have to acknowledge that it exists. We need to try to prevent it and treat these patients. So that there has been billions of dollars invested, maybe not enough, and certainly not happening fast enough. But at least that is a start, and it's certainly not where we were in 2019. We are seeing sort of greater progress, I think, in recognizing ME/CFS, myalgic encephalomyelitis, chronic fatigue syndrome, and so I think that large patient population is at least getting greater acknowledgement about their debilitating illness and their need for adequate treatment.
Yes, and the terrifying thing about long COVID is I had a couple of friends early on during the pandemic who had long COVID, and they were athletes, they were young, they were healthy, and oftentimes I think there's perhaps this misperception that this only affects certain people, the most vulnerable, whatever that means. But really, we really don't know what the true prevalence of long COVID is, right? We just can't measure it. We don't know how many of us are affected by it. To your point of how much more investment we need to do in understanding how to provide care for our patients. Joanne, I think I'm going to hand it over to you because I'm noticing the time, and I know we're going to be starting Q&A in roughly 10 minutes. So back to you.
Right. Well, thank you so much, Prativa. And Jason, when you were talking, I kept thinking about the outbreak of Ebola in 2014 and 2016, and how naive we were initially, because we thought that if someone was surviving Ebola, that was the end of the story. And then before that outbreak, because we had more than 28,000 people infected, 11,000 people died, we have a huge cohort of survivors. And then we realized that survivors were actually patients. And they all have all sort of sequelae. And then we did cohort, and they have like different, impact on neurologically, impact of ophthalmic arthritis. So it was massive. And it was a huge eye opener for us, because we used to just say, oh, you survive, go home. And now we don't do that anymore. We follow them up. We make sure they have care. And so, do you think that COVID-19 will somehow contribute or be possibly a game changer on increasing awareness about post-infection sequelae from different diseases like Lyme disease, like Ebola, like chikungunya, like COVID-19?
Yeah, so instead of I don't know I'm bad at math, but that's more than 10,000 Ebola survivors from my calculations. But we know that with SARS-CoV-2 that there may be as many as 400 million people around the world suffering long-term complications of this infection. So that's many-fold times more. So yeah, I think. Definitely, but I can think of Daniel Cherto, this critical care doctor who worked with MSF in West Africa during the Ebola crisis. And from that experience, when he came back to work at the National Institutes of Health in Bethesda, he was doing the autopsy work on COVID victims, and look to see where the virus was going in the bodies and brains of these people, knowing from Ebola that there is some chance that there may still be virus that is continuing to persist in parts of the body and brain, and certainly he found that. So I think that he subsequently decided that he would do research into what happens after RSV and what happens after flu. And so I think those sorts of studies are really important. We don't know enough, and we make assumptions. Actually, another area that I think was super interesting, and where we had made perhaps incorrect assumptions, was around maternal infection. We certainly know that COVID was causing a lot of obstetric complications for these women who were pregnant with COVID, increased risk of ICU, needing the ICU and needing a ventilator and things like that. We were initially testing newborns, doing a nasal swab, and the very small percentage were positive. So it was assumed that the fetus really wasn't getting any effects from a maternal infection. But then when we started doing more detailed analysis, looking at different tissues, different time points and things, I think it's fairly clear that the nasal swabs on newborns was not a reliable indicator. And now, unfortunately, some of the epi data are showing a signal of neurodevelopmental outcomes that are not particularly good. And we know through history that maternal immune activation, maternal infections are associated with increased risks for things like schizophrenia in the offspring, depression, dementia, things like that, which obviously don't appear immediately. They may not appear for another 6 or 7 decades, but we need to be alert for that.
Right. Thank you. So let's switch gear and talk about trust, institution, leadership. These are like big theme in your books. And then you say at one point, you said unmet expectation erodes public trust. And so the public trust, and then when we are into this slippery slope of distrust, then we go into misinformation, disinformation, sort of echo chamber. So what is your take on that? Is what can we do to fight this? And how do you see the role of you as a journalist, us as academia, and collectively as well the authority and everybody? Because and I think we're quite aligned, because you finished more or less your book like this, is I think that next time around we're going to be facing maybe a new emerging infection, and then we will deliver, technically speaking, with the medical countermeasure, but I don't think that we will deliver as human being and in our behavior necessarily. We might be again hoarding a vaccine and not being solidarity and all that. So so tell me, what are your thoughts about that?
Well, I don't profess to be an expert at all on misinformation and how to handle that, but I do see efforts like people like Caitlin Jadalina. She's your local epidemiologist out of California who has been working at the grassroots level, trying to understand why people have certain beliefs and really listen. I think a lot of there needs to be a lot of listening rather than talking down to people. One of the things that I think is super important and needs to be expanded globally are science media centers. The UK has one, Australia has one, New Zealand has one. Many countries have these science media centers, which are there to protect the public, try to get the public better science information through a better science media, upskilling journalists like me, giving them better skills in reporting on these sorts of outbreaks, with the hoping that we'll be better science communicators. And I think that has been certainly super helpful for me. I'm actually have to disclose that I'm on their journalist advisory board, but for example, when new research comes out, science media centers gather expert opinions on the studies. So journalists can just look at what these experts are already saying about papers, and able to get very quickly a good cross-section of views. Things like that are super important. So, unfortunately, mainstream media is shrinking, and people are increasingly getting their information from social media. And so that's a harder beast to tackle. But I think we have to work on ways to get better science communication to help inform the public in a more meaningful way. Sorry, I'm rambling. I think it's my jet lag.
No, I think great. And we had those discussions before or today, earlier in the day, and when we were saying, and we were both in agreement. One of my take on epidemic and why somehow I find it fascinating is just because I always find it very humbling as an exercise, because you definitely get it wrong regularly, and so you have to be humble and be able to redress and re and refocus on the way forward with new element of emerging I would say data. So it's very, very humbling as an exercise. And that's what as we were remembering ourselves, how Mike Osterholm, who was our keynote speaker for our launch, told us how humility is a key thing in tackling epidemics. So I'll turn it over to Prativa, and I think we're going to go soon in the Q&A, but one more question, Prativa?
Yeah. I just wanted to thank you so much for speaking about the science comms piece. I think we're all reflecting on how better we can do as scientists, as epidemiologists, next time there's a crisis, and to admit when we don't know and to be transparent rather than to say something and then change your mind afterwards. So very much agree on the humility piece. We apparently have a couple more minutes, so and the chat is buzzing with lots of thoughts. One question in particular that I see in the chat, though, has to do with the Science Media Center that you had just mentioned, Jason. Mary Jo was asking, do you find the Science Media Centers, are they effective right now? The UK, for example, is not doing well regarding COVID, long COVID, and understanding the reality of COVID at all.
I'm not that familiar with what the UK Science Media Centre is saying on long COVID. I think we have to acknowledge that reader interest has diminished on anything to do with COVID. At one point, the stories I would write would get millions of readers, and like that was for me unprecedented and mind-boggling. Today, a well-read story would get a tiny percentage of web, clicks that they would previously. So while perhaps long COVID is not discussed as much on platforms like the UK and Australian Science Media Centre, I think it unfortunately reflects a lack of interest in anything to do with COVID. So we're all as journalists we're wanting to write stories that are impactful and important. But if you spend 3 months writing a story and 300 people read your story, it's not a really great use of your time. So it's a challenge, and I am not at all trying to diminish long COVID and the importance of it, but it's a challenge to get people to want to read these stories. So it's not necessarily that we're not reporting them, because maybe we're not reporting them, but it's also that people don't want to read this stuff, unfortunately.
And it kind of goes back to the information ecosystem that I think that we're all in, where, first of all, we have very short attention span, but a lot of misinformation circulating out there. A lot of us are getting information from lots of different sources than just traditional media. Would you have any thoughts on how Bloomberg or you are kind of addressing this new information era that we're in? How do you get people to be interested in your stories, whether it's about long COVID or about anything science related, to kind of combat a lot of the anti-science sentiments we're seeing?
Yeah, look, I think that we have to be creative and innovative in our storytelling. Um, so the story that I talked about earlier on Dean's Curse, that story actually did relatively well, and I think it might have been because this whole Ondine's curse thing was for me, it sounded really interesting. I didn't realize that it was actually, I thought it was a fairly sort of a quirky thing, but in fact, it turned out that many people were experiencing this breathing problems, perturbations of their normal breathing drive. Um, I think we just have to be creative and more thoughtful about how we can engage with readers on stories that do matter.
Absolutely. Joanne, I think you had a question for Jason.
No, it's just because the chat is really moving fast, and 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 uh and then there's a sort of I would say challenging question from one of the person on the chat who was saying that at one point, because we were, I don't know if you had the same thing in Australia, but in Canada at one point, because it was état d'urgence, a state of emergency. Basically, government were just going and moving, like trailblazing in terms of the answer. And then there was nothing in parliament, so there was no period of question. And all of a sudden, the journalists were the one who could ask questions to our leaders. We were not having access to it. And I was wondering, how did you feel in that kind of position? And do you think that the journalists were have all the tools to ask the difficult question, and how could we help us in the academia in that respect?
Oh, okay. Look, I was so fixated and trying to understand the dimensions of COVID. I wasn't really paying much attention to what politicians were saying. I was, definitely interested in the move to come up with, well, firstly, to understand what COVID was doing to our bodies, and then how to treat it, and the whole sort of remdesivir, and of course we went through other drug trials and things to sort of come up with antivirals and monoclonals, and then the vaccines became a big story, and um, I wasn't really so much focused on the political response. I was in Melbourne working, and we had, many lockdowns, I think about 7 in total over almost 2 years. So those certainly had an impact. And I was definitely aware of some rules. We had penalties for not wearing a face mask outside. So if I was walking a street with nobody else on the street, but not wearing a face mask, I could get fined. And I thought that was a bit silly. Not that I didn't believe in face masks, but I also believed in appropriate wearing of face masks. And when you're not seeing anyone else around you, yeah, anyway. Uh, so there was, yeah, I wasn't really so much focused on the political aspects.
Just to continue this train of thought, I think a lot of the chats that we had today touch on the responsibility of the patient or the population to wear a mask, to do this, to do that. And then we think about the inequities, even with long COVID, and who gets access to treatments, who gets access to the information, who knows how to advocate for themselves because they have the right support to do that. Can you speak a little bit about the inequities? I mean, we talk a lot about vaccine inequities and whatnot, but I think even in the ways that COVID affected some of us way more than others, and the access to treatment, access to care, ability to stay at home when that was very much the messaging that we were giving. Can you speak a little bit more about that and whether we've learned structural lessons from the pandemic that will allow us to invest in things like better air control or quality rather, instead of just focusing on the individual?
Yeah, for sure. Yeah, we definitely, realized too slowly that that SARS-CoV-2 was being transmitted through the air, in aerosols, and the need for improvements in air filtration and ventilation and things like that. I also think of, I mean, I was fortunate. I was working from home. I had a reliable income and no risk of infection in Melbourne working from home. But the people we think of frontline workers, obviously in hospitals and emergency services and things, but there were people working in grocery stores and pharmacies and other places, often in low-paid jobs, often migrant workers, and their exposure risk was really high. And we know that they were heavily burdened with long COVID. And then there were impediments for them in accessing care and treatment and things. So I think even there's probably still a lack of adequate awareness of long COVID in certain groups, mostly because of cultural and language barriers as well. I also think of care homes, nursing homes, long care facilities where um, uh, often it's fairly low paid migrant workers who are doing the majority of the certainly the low paid work, and they're working across multiple centers, and so um, their their exposure was high, but then also the potential for transmission between care centers was also really high. So I'm hoping that situation that led to really high mortality in care homes has really highlighted inequality in aged care and inequality among the people working in these facilities to recognize those vulnerabilities in particular.
Thanks, Jason. Sean, any last questions from you? And then I'll start looking through our chat. We have 13 minutes left, so we'll start the Q&A portion shortly. So please type your questions to Jason on the chat, please.
Well,
Sean?
I think one question I'd like to because I love your book, and I thought it was such an amazing read, because all of a sudden we follow the movie not by chapter but as a whole, and then it was such a good thing to go through. But of course at the end you leave us, with doubts about how we're going to do next time around. So I was to finish on a sort of a hopeful note. I was wondering, what you would like the book to leave us with in terms of a more hopeful tone, about tackling epidemics.
Yeah, well, I think on the technical front, we have so many additional tools, wastewater surveillance, home testing, rapid tests. We know much more about ventilation and aerosol transmission. We have mRNA vaccine technology. We have many wonderful, fantastic genomic surveillance tools. Um, but unless the society is going to believe in vaccination and be willing to comply with public health recommendations and trust that they're going to be beneficial, we're going to be fractured and polarized and divided, and we will crumble as a society in response to these threats again. I just can't see us, unfortunately, doing better if we're going to continue to be divided and polarized and so mistrusting. So I think the work needs to start now and trying to rebuild as a society, remembering what had happened and how much it cost us and why it's so important that we do better next time. Because we know for sure that there will be more of these events, not fewer.
And just investing in a lot of the infrastructures that we had put together very, very haphazardly during COVID, and a lot of which has kind of, been dismantled. I feel like just making the argument that we need these things in order to catch the next one or to be better prepared for the next one.
Yeah, look, I think our health systems are tired and more fragile. I mean, we saw the response to Mpox when it initially emerged, and we saw how there were bottlenecks and delays in testing and vaccination delivery and even communication. Largely, I think that reflected the fatigue within the health system. So many people left, many people died, many people got long COVID. We really need to be supporting the resilience of our health system.
Yeah, so as you finish your book and you said I hope we're going to be not, but I hope we're going to be wiser, not only older. So we all hope that for ourselves. Okay. So we're going to go on. There's a queue of questions, so I'll let you go through it, Prativa.
Thanks, Joanne. I'm going to start with something that I saw pop up a little while ago. With all the information now from Annie Daniel, all the information now available, including about 500,000 studies, why do you think even experts are not advocating for more infection prevention, like air quality and masking, as you mentioned, even flat out rejecting it?
Look, I don't understand why. In Australia we have amazing scientists like Lydia Moralska, who I think really led a lot of the global effort to recognize the importance of air quality and ventilation. It requires building standards, changing, transportation, mass transportation, bringing on these standards to improve, because, it's a no-brainer for many of us here, right? Knowing that it's not only going to be preventative for COVID, but all respiratory illnesses, and there are so many that cause sickness and often long-term complications. So I'm sorry, but I have no real good reason to understand why there isn't more effort on this front.
And just adding, there's a lot of conversation happening in the chat about the frustration around this. When the general population sees that physicians aren't worried about being infected multiple times themselves, or if their own children get infected, it's difficult to convince people otherwise, especially when they see government officials and public health leaders YOLOing, as Mary Jo says in the chat. So I think it kind of goes back to the perception that people have of this virus, that this was an acute thing and that we've moved on. But I think it goes back to the collective trauma piece too. I mean, we talked a lot about long COVID, but people were isolated for decades, for a long time, for a couple of months. For many, they were not able to go to funerals, to go to weddings, and so as humans, we're social creatures, and I think the trauma of going through that very, very depressive period makes people want to forget, which is understandable, but forgetting something like this is not going to better prepare us for the next emergency.
Yeah, I think there's a cost of forgetting, sadly. Yeah, well, at least not doing anything about the lessons and not learning and heeding from the many lessons that we can learn from the COVID experience.
Jason, we also have a question from Marie-Michelle who's asking, how do you think long COVID and ME/CFS is affecting the global south? Are you aware of any studies on the subject?
Yeah, I'm aware of one study that I didn't look at in great detail, but it did show a variation in prevalence of long COVID across different geographies. And I wondered to what extent some of that may be, cultural. We know that there are differences, for example, in autism prevalence. And I remember reading about why that might be the case. And one thing that sort of uh, struck me as interesting is that in different parts of the world, there are different cultural, perceptions of around these things. So it may be just differences in the way we measure and the our ability to collect data. I'm not really sure that that humans are that different in one part of the world to another, that there would be any sort of intrinsic reason why there would be a remarkable difference in prevalence. Yeah.
Thanks, Jason. Something more to investigate, I guess, and put resources towards for sure when we think about the inequitable access to resources for doing simple research as well. We have a question for both you and Joanne. I think a lot of the conversations, we briefly talked about this a little bit about the question of trust, and I think it's just as important to talk about what can we do to be trustworthy of the populations. And one question that kind of speaks to that is how can we reduce mistrust in public institutions, especially when it stems from racialized communities who have experienced exploitation, violence, etc., from such institutions? Jason and Joanne, over to you.
Maybe I go. He has more to say probably, so I'll go quickly. I think the way I do it for me is very simple because when I was speaking during the COVID, but during as well Ebola in the past, or during outbreak of cholera in the global south, is always having a very simple narrative in terms of, and telling at the outset to people, this is what I know, and this is what I don't know, and this is what I would like to know. And by making it clear at the outset, and then sharing some vulnerabilities, and the fact that the only certainties you have in times of uncertain times is your uncertainties, and that's it. And then I think people overplayed certainty because they wanted to reassure people, and I don't completely blame them, but we learned the hard way that by doing that, then you can only disappoint people, because that's the way things unfold. So you have to have the courage to say that you don't know, and that you are looking for the answer. And then the day you're going to have the answer, then you probably would be able to give better guidance. But while we don't know, then for me, the precautionary principle must apply. And this is the thing that we didn't do. When we were arguing, is it airdrops or is it aerosols? And then we just said, no, we kept pretending it was the one that has the least impact. That was a complete mistake. And I always say, for someone who's been a front line of crisis, that honestly, hope or best case scenario is not a strategy. You just have to prepare for the worst case scenario. And that's what the only downside of that is you may have over prepared, and big deal, honestly, not a big deal. I'll stop there.
Yeah, on the structural racism, look, I don't really have any great answers, apart from just stop with the structural racism. And but on the communications, I think, as Dr. Liu said, we really need to acknowledge uncertainty and be more transparent around it. Often we make assumptions, I think there were assumptions made about transmission droplets versus aerosols, and we didn't disclose that this was an assumption that hadn't actually been tested, and in the early days, and so a lot of recommendations like not to wear face masks or to wear face masks were initially backed by insufficient data, and I think we needed to be flagging as journalists and media and public health just how uncertain everything was, and that advice will change as more information comes in, and bringing people along on that process of discovery.
I think there's also something to be said about all of these being applied during the acute phase of the crisis, but also if we look much more broader than that, giving people reasons to trust health systems. So, for instance, I'm thinking in Quebec, there are thousands of us who don't have access to primary care, right? So things like that, how can we possibly increase trust by making our systems trustworthy, by giving access to primary care, which is really the front point of contact, or should be. And I think that would also deal with a lot of the misinformation that we're dealing, where people wouldn't be searching for information elsewhere if they have a doctor or a pharmacist or a nurse that they trust. So I think, there's the acute phase where we need to do a lot better. But I think even during quote unquote peace times, which do we even have those anymore? There's a lot that I think we need to be doing on that front too.
Yeah, for example, having Indigenous clinicians talking to Indigenous communities, I mean, that's so important. People are more likely to trust someone who kind of looks like them and knows them, their community, for sure. So investing and addressing some of those inequities is a very important thing to do in peacetime, for sure.
We are at the hour, but the chat is very engaged. So if you can stick around for a couple more minutes, we have a couple more questions in the chat for Jason. One has to do with just the narrative of even how we talk about COVID. Someone from the chat, Adara, is asking, do you think it is dangerous to discuss COVID in the past tense in 2016 when it is still alive and well, and the balance of figuring out how to deal with the next one, while still being able to adequately discuss the effects of the current state of COVID?
Yeah, look, it's a kind of a tricky one. Definitely, COVID is still obviously a factor in our health. It's still causing severe illness and deaths. Every month, I see that there are hundreds of deaths in the US still from COVID. Um, so it's not in the past. We think of the COVID pandemic often as in the past because the emergency phase ended officially a couple of years ago. And I think that collectively we want to put it in the past. But yes, by no means is it a has it stopped being a current threat. Definitely the threat has diminished thanks to vaccination. We're very fortunate that we had highly effective and pretty safe vaccines that did provide that level of immunity that has reduced the risk of longer term complications and severe illness and death. But it is difficult if you were to ask people on the street if the pandemic is over. Most people, I think, would say it is. Um, and I think one of the interesting thoughts around, when a pandemic is really over is that it's society that decides when a pandemic is over. It's not, one group of people, it's collectively. And I think collectively society has decided that it's over. Whether it is over or not, is another question. I mean, still, the 2009 H1N1 virus is still circulating, yet that people accept that that pandemic was over. H3N2 from 1968 is still the 1968 flu is still causing deaths and severe illness, and yet we are pretty happy to put that one to bed. So it's an interesting debate. I don't deny that COVID is still a significant health threat, though.
Thanks, Jason. Joanne,
We're
back
going to
to
need to close here because we already went over the hour. But we want to thank you so much, Jason, for joining us. You're so close to us, coming all the way from Melbourne, but we're not with you. So we this is like live again COVID. And then we'd like to thank as well all of you who've been attending online. This is great. You've been so active on the chat. I could not follow, but this has been great to get all your feedback, your engagement. And I want to thank the Department of Global and Public Health for hosting the event with Pearl and all the support that we got from our people from the office. And then you may remember 6 years ago, this was the day that we declare a pandemic. So on March 11, 2020. And so I think that we need to make the promise that we're all won't be only older next time around, but we're all gonna collectively be wiser and more humble to do better next time around. So thank you so much. Thank you.
And thank you for hosting me and giving up an hour of your evening to have this discussion. It's been really great. Thank you so much.